Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMGA's public policy podcast. I'm here today with an all-star crew as always, and let's introduce ourselves. I'm Chet Speed, your host.
Hi, everybody. My name is Daryl Drevna. I'm the Senior Director of Regulatory Affairs at AMGA.
Hi, I'm Lauren Latney, Director of Government Relations at AMGA and independent bookstore lover.
Oh, nice. Can you drink coffee in independent bookstores? Do they allow that?
I think they allow anything they want. They're a small business in America.
They're independent.
I love the
Yeah.
smell. It's just a nice.
We love our independence.
Yeah.
Yes.
Jamie Miller, Ambassador Goodwill for AMGA. I like record stores.
Do you? Are you just saying that for the kids?
No, I like the smell.
Okay.
Yeah.
A vinyl?
Yeah.
Sounds good. Anyway, I Kennedy wasn't paying attention. Okay, we always start with a question. Did not have a question in mind, so here we go. Coffee or tea?
I'm a tea girl. I'm going to go ahead
What
and interrupt
kind of
you.
tea?
I drink tea depending on my mood, so I don't have like a favorite. It just depends on what the vibe is for the day.
Oh, what about today?
So I stole a bunch of teas from annual conference.
Hopefully our CFO's not listening.
Yeah, our producer is nodding because he saw me yank massive packets of tea.
He's an accomplished.
He was silently, approving. So there was a coconut cream tea from the Art of Tea that I really enjoyed taking mass quantities of.
No kidding.
Yeah.
Sounds good. And it was...
I was not the only one, but I won't name names. It was free. Yeah, it was paid for by AMGA.
Yeah. That's outstanding. Jamie?
I do like coffee, but Lauren and I went to tea one time, and I didn't realize you shouldn't drink 5 glasses of tea when you're in one sitting. So I had a headache.
But it was all you could drink.
Yeah.
But maybe you understood that all
sandwiches.
you can drink is a lot less.
When they give you the little sandwiches, oh, it's so good.
So the British won World War II.
Very masculine. Very masculine.
Yeah.
I'm a coffee drinker.
Okay, good.
Yeah, no
good.
sugar, just a little bit of cream.
Really?
Yeah.
Well done.
So, yeah. And my big thing now is trying to figure out how to get the perfect cup of coffee when I go camping. Because,
That's hard to do.
It is.
There's no Starbucks.
There is no Starbucks.
In the Canadian wilderness, is that
grind
right?
your own
Is there a certain region of beans that you like? Or
I'm not that sophisticated.
No.
Yeah.
Folgers.
Folgers, yeah.
I'm with you, Daryl.
Yeah.
Coffee.
Coffee side.
And I refuse to go to Starbucks. Absolutely refuse.
Unless you want to sponsor this podcast, we will start.
Yeah, right. Starbucks. Sponsored by Starbucks. Coffee lemonade, whatever that is. My daughter likes it. So hopefully all of you listeners are hearing us with our brand new microphones. We have a new setup, which is so new it didn't work, which is why Mike I, our producer, is at the table with us. We're excited to have you. Want to say hello?
Hey, folks.
Yay! There we go.
That's all you're going to get.
Does exist.
At the best in the business right there. Okay. We have been talking about this issue for a long, long time. But we are going to chat for, a good 15 minutes about budget reconciliation, which is going on in Congress right now. And specifically, we're going to talk about how the budget reconciliation process may actually impact the Medicaid program. So let's start off with a very brief elementary question. What is budget reconciliation?
It's basically a procedure to get Republicans to be able to pass a bill in the Senate. So the House...
Or Democrats.
Or Democrats, yes. Yeah. But right now, the House has a certain amount of Republicans that they need. They can get a majority. They already have a majority, but in the Senate, you need 60 votes to pass many things, except for confirmation appointments to CMS and HHS and things like that. But now this is a way for whoever's in power to pass a bill without 60 votes.
Right. So no filibuster in the budget reconciliation process. Is that right?
Correct.
50 or plus?
Yeah.
Okay.
It's just the fine print part then.
Right.
Yeah.
So it makes it much easier for when one party's in power with the House and Senate and the White House. It allows them to pass things without a majority.
Yeah.
With a majority vote.
They've done it on Medicaid. They had to do it on parts of the Affordable Care Act.
Mm-hmm. That's right.
Because as you remember, Ted Kennedy passed away during the debate and they were elected
Scott
a
Brown.
Republican from
Scott Brown,
Massachusetts.
Yeah.
Other than Mitt Romney,
59 votes.
yeah. So
Now we're going to get New Hampshire for House or
That's
Senate.
right.
Yeah.
Yeah, well, there's openings.
Yeah.
Everyone needs a job. Okay, so budget reconciliation is in process right now. And Medicaid, you hear Medicaid a lot as part of these discussions. Why is Medicaid in the news so much?
It's interesting. Medicaid is in the news so much because Medicaid is a large program that is funded by both the federal government and the state. There has been, when you talk about budget reconciliation, each committee is given instructions. Energy and Commerce is given instruction to cut almost $800 billion. Medicaid is a very large program, and it's something that Republicans have been targeting for quite some time in terms of the belief that there's a lot of fraud in the system, that there are a lot of people who should not qualify who are currently on Medicaid because it was expanded during COVID. And so there's like an attempt to sort of claw back some of the things that allowed Medicaid to expand over the last couple of years.
Right, Republicans aren't a big fan of the expansion population that happened as part of the ACA. We mentioned the ACA earlier, and that sort of added a large cohort to the program. Is that right?
It is. And it's also important to remember that, a lot of red states expanded Medicaid, but they weren't expanded under state legislatures or from the governor. These were ballot initiatives. So I think it was like 7 purple and red states have expanded through popular vote. And then all but one of those states voted for Donald Trump. So this is popular even in red states.
All right. So you also mentioned instructions which go to various committees on the Hill. And those instructions are basically you come up with savings or you spend some money. And you mentioned the Energy and Commerce Committee specifically, which has jurisdiction over Medicaid.
Yes.
And they've been instructed to save $800 billion. Is that
Yes.
right? No, 880? Anyway, 800
around,
and a lot more than $500 billion.
Yeah.
And so they have this jurisdiction over Medicaid. So the idea is that a big chunk of money from Energy and Commerce has to impact Medicaid.
Yes.
Is that right? Okay, so over 500 billion, I think is the term. Okay, so what is Congress looking at as far as specific issues within Medicaid to review, address, or cut?
Well, some of it is waste, fraud, and abuse. The purpose of doing that is because Republicans don't want to go on record of saying they're cutting beneficiaries. So they want to give that lovely job to the states and let the states do it. We also talk about Medicaid work requirements, which is already established in some states already. And perhaps looking more at the Medicaid provider tax, which is something that's been coming up more and more, I believe.
Yeah, and it's a complicated situation because, as you mentioned, like the Republicans don't want to actually directly impact the beneficiary. And we'll talk later about how even if you do address the provider tax or you talk about work requirements, it's still going to impact the amount of people and the type of care they have and coverage, and which will impact more than just the Medicaid population.
Yeah, they're taking a look at all the various financing mechanisms that the states use to come up with their share. Lauren mentioned Medicaid's a joint program, federal, state, and the statute, has parameters around how the states are allowed to, or how it dictates how the states are allowed to come up with their share of the money. And if the feds, through the Energy and Commerce and Congress, want to amend that or change that to get savings, there's a couple different policy levers that they can pull. Or change, and this state financing mechanism is one of them. This provider tax, which essentially is a way the states are going to raise money by taxing providers, which then turns around, which they use to draw down federal funds. And there's a lot of criticism on that. Though basically, it's like a laundering scheme, but it's totally legal. So I don't think that's money laundering is illegal. This is a legal mechanism that's been going on for years, and it's a way for states to come up with revenue they otherwise wouldn't have.
And I think an interesting point to mention on yours, Daryl, that this is a state-federal program. 49 out of 50 states have some form of constitutional amendment requiring a balanced budget. So we cannot make an assumption that if the federal share decreases, the state's going to be able to do anything unless they raise taxes on their population, which
right, they're going to have to come up with the revenue somehow.
They're not going to do any T-bills to raise money.
Yeah, and I just practically speaking, I think I'm not getting too far to limb here. I don't see how they do it.
No, you got 3 options. You got raise taxes, You have cut education spending, which is usually the largest part of government, like a state's budget, or you find ways to drop people from your Medicaid rolls, or you drop reimbursement, like those. And no governor wants to go on record
Yeah,
raising
the
taxes.
states are going to love those options,
Yeah.
right?
Yeah.
That's
Well, as a Maryland resident, they're already increasing taxes by 1.6 billion. So this is not helpful for us Maryland residents, nor anywhere, quite frankly.
The other thing they could do if they didn't want to get into the nitty gritty of the provider taxes, and that you could just, it's almost like the nuclear option here. You start changing around the FMAP, which is there's a floor, like the matching funds the state draws down. It's a percentage based on, the share of the low income population and that sort of thing. And there's a floor of 50%. So every state gets at least a 50% match, and it goes up essentially how poor your state is, right? And they could just reduce that. And, instead of a state getting, 75+%, they could just bring that down. But it leads to the same problem. If you're going to draw down fewer federal dollars, but the states have got to make that up somehow.
And just adding to that, there's a lot of states who, as you mentioned, Daryl, have a larger federal contribution, the state contribution, depending upon like various factors. A lot of those states that have a large federal contribution are red states. And so it's not just the governors, it's the senators as well who are going to be hearing from their constituents on this.
Which is why you see like Josh Hawley, who's not someone I really would find into this conversation, making a statement about like the possibility of cutting Medicaid would be detrimental to his state. There's also 11 sort of like swing state Republicans who are also kind of going on record of saying like this is not good for us, not from our Medicaid population, but also from an electoral standpoint for us.
And we've learned, we've had members testify before Senate Finance and some others that every single state in this union is rural. And so the rural aspect of this is going to have major consequences for every single senator.
So, if you're looking at it, like in a perfect world, is this how we would structure a program to finance it, right? Like, would you want to tax providers to turn around? And then in the statute, I should say, there's no guarantee that they're going to get that money back, right? There's some safe harbors and all that. So it's not a one-to-one type situation. Like, I'm going to take this to you and you're going to get it back somehow. That's not how it works. That said, they had to get creative because you've got this population that needs healthcare. You've got providers and healthcare systems and doctors who need to get reimbursed for the care they're providing. And this is sort of the convoluted system that's come up over time, and really going after or changing significantly these provider taxes or intergovernmental transfers really pulls the rug out from the whole system.
And Joe, you bring up a really valid point that if this $500 billion, $800 billion is there's some reform, provider tax, and other things, those savings are not going back into the healthcare system. They're going towards deficit reduction or for other policies like extending potential tax policy. So this money is not going reinvested back into the health sector.
Right. So this is just another long line of potential cuts or actual cuts that our members are facing.
Okay, so a lot of mechanisms to reduce Medicaid costs, and you hit on almost all of them. Eligibility rules, provider-based taxes, decreasing the FMAP, looking at the expansion population. So obviously huge impacts that these things potentially might have. AMGA actually surveyed our members about what the impacts of these cuts might be. So we have a little, some little intelligence on what our members are telling us what might happen if Medicaid is cut between $500, $800 billion over the next 10 years. So let's talk about that survey. What some of the questions we asked were, what percentage of our providers might consider cutting patient-facing services? Some might limit Medicaid access. There was discussions around staffing concerns and possible layoffs, and some financial stability issues. So let's talk about some of the findings from the survey, because I think they're important for our audience to hear. Sharon wants to. Sharon.
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 Lauren has
But-
been replaced by
Yeah,
Sharon
I
in the
know.
middle of the
He got
podcast.
recast
I was
mid-episode.
recast. This feels like The Simpsons.
Yeah.
I was just, and there's Sharon's notes are on the table
Oh, okay.
from a month ago. So that's, anyway,
Okay.
Lauren. And
Yeah. So this is what I think this is our largest survey we've ever done, right? Like in terms of the length of questionings, in terms of participation, because coming out of annual conference, this was the biggest issue that our members were talking about. And, the survey results sort of reflect that. A staggering 85% of medical groups that our members are expecting to eliminate patient services. And you're looking at about 67% like seeing either additional reductions or eliminations. This is across many specialties. You're thinking about providers in rural areas and what the impact would be on medical groups and hospital systems there. I mean, it's really, really scary in terms of these large numbers because Medicaid pays for so much, right? So Medicaid also pays for maternity services. And we're looking at 47% of our members saying like they might threaten access to these services. And that's really bad in rural communities that like largely serve Medicaid populations.
I think on top of services, we talk about close or restructure facilities. We've heard from our members saying 52% are looking into that. 81% are looking into closing or restructuring clinics. This isn't Medicaid clinics. This is not Medicaid mental health clinics. These are mental health clinics. These are clinics. So these Medicaid cuts will impact beyond just the Medicaid population. It's going to impact how far you have to drive to go see your physician, how long you have to wait at the ER, other things like that. So I think these results are rather concerning.
Yeah, especially when you consider that a lot of times hospital systems are the economic engine of communities. They employ a large amount of the people who live in these communities, whether you're nursing, you're doing administrative staff. If these hospitals close and there's no sort of replacement for them, that means these communities often die. You think about moving in businesses into these communities in order to sort of restructure what the economic system is. They don't have a hospital, they're not going to come. It's just point blank. And so there's a large impact that it's really troubling to see if these things go into place.
And in those facilities, we've been hearing that 70% of the employees, 72% of our members are looking into furloughing and layoff all types of employees, clinical and non-clinical, and at least 51% are clinical staff. They're looking, and that's going to impact the day-to-day patient getting access to a random physician or PA or NP, and that could be really detrimental, not just to the patient, to the community, but like as we all know, if you don't have good access to your care team, then that turns into worse healthcare results.
all right. And so it sounds like I think almost 3 out of 4 of our members said they would further lay off staff, and half of those layoffs would be physicians or NPs, and I believe 70% would also lay off medical assistants and LPNs and RNs. So we are talking a humongous access issue, which obviously is problematic. And I do believe almost half would consider closing, as you said, clinics or actually rural hospitals.
Yeah.
And sort of the flyover territory that makes up the vast majority of our country. So that's an issue. There was also talk about programs they might eliminate, such as telehealth.
Right. So it's really you're pulling that much funding out of the system, and I think the folks who are in charge of our groups and our systems need to take a hard look at like where do we have the resources, the funding, and telehealth is one of those things where here's a mechanism to reach out and really expand access, but if we don't have the resources to fund it, we just can't do it, right? So it just goes away, and all of a sudden that's going to create even more access issues, to pick up on what Jamie and Lauren have been talking about. So it's really, if you're going to pull this much funding out of the system and not replace it, systems and practices are going to take a hard look, and telehealth is one of those things that is a lifeline for a lot of folks in this country, and it just won't be available anymore.
Yeah, you think about how telehealth is thriving. It's really thriving in these southern red states, right? Georgia is known as probably one of the most active telehealth states in the country. You know, Alabama, you have Mississippi, and if you let these who have very large rural areas, you shut down telehealth. which means you're going to rely back on transferring people to hospitals. And, one of our members talked about, it takes, if you have 2 ambulances in your city and someone gets sick and you got to go to the nearest hospital center, that ambulance cannot leave until that patient is admitted into the hospital. So if you're doubling patient time, then you're one less ambulance in your city that you can have access to.
And Dale and I were EMTs, so we know
Yeah,
that.
we know.
We have been there.
Transferring care.
Well,
You don't
for
leave
a
until
long time.
you're there for a while.
I think also just for the Republicans,
And by the way, Dale and I are American heroes.
Yeah,
for that.
just-
Okay, great. Thank you.
for Republicans, we've been communicating about the telehealth issue for a long time, and beyond the economic impact of like facilities closing, if you're a caregiver to a Medicaid or Medicare beneficiary, the amount of time spending taking that beneficiary to the doctor is problematic if you take time off of work. So if we have telehealth in the system, it really helps. And we've heard that from especially our members in Alabama, how much time it saves, not just the patient, but the patient's helpers and things like that.
I think telehealth is really a success story coming out of the pandemic. There's definitely some lessons learned, and so it's like, and I think we're working to expand the flexibilities that came out of the pandemic on a more permanent basis. I know there's conversations going on, the Connect Act and all that we talked about a couple episodes ago. But in this type of situation, would just I think I've used this phrase already, pull the rug out from under it. So I think that's my phrase of the week. So
Okay. Yeah, and so I think we also touched on, this is obviously, these potential cuts are directed at the Medicaid program, but the spillover effect to all communities is well beyond just the Medicaid population. You'll have ERs will be, potentially overwhelmed. I know locally, our local hospital, there's a 7-hour wait for ER, especially on the weekends, and that just might double. And then obviously, if you want to get an appointment with a physician who might have had to move, those times are going to increase also. So everyone's going to be impacted by these potential cuts. Is that fair to say?
Yes.
Okay, fantastic. All right. Well, not fantastic. I mean, thank you. No, not fantastic. So what should our audience be watching for the next few weeks regarding this debate?
I would say there's going to be a lot of committee activity. So the blueprint for this reconciliation passed 2 weeks. Well, it passed this a few weeks ago, and then the committees are going to be considering policy to address Medicaid reform. That will be happening in early May, and we could see something on the House and Senate floor, maybe by Memorial Day, maybe by 4th of July. Which means that if this becomes law by July, all this policy is more of Daryl's purview, but will become in regulation by the end of the year. So this is not something we're just this is going to be happening very quickly. And so everyone needs to get involved in reaching out to their members of Congress about the impact of these cuts.
Okay, so this is happening quickly, and there is a call to action here. Lauren, I know you're very active in our grassroots work. If you could tell the audience how they can contact you and all of us.
Yeah.
Because I think they do need to talk to the members of Congress. Is that fair to say?
Yeah. And one of the best things about AMGA is we have so many different on-ramps into advocacy. One of them is the district advocacy program, which I run. Essentially, it's a one-stop shop. We will set up the times for you to meet with your member of Congress or their staff. We provide you with talking points, profiles, everything that you need to make your life easy. It's just clicking on a Zoom and chatting with folks. So please feel free to reach out to me. Our information is going to be on the website. We also have our grassroots network sending personal letters to members of Congress that actually talk about what is going to be the potential financial impact on these services on your hospital, your medical groups. People need numbers, and that's very important.
In the grassroots letter, we'll have a survey results and some other information. If you just go to the advocacy site and go to AMGA Advocacy, there'll be a Medicaid button there, and it have all this information for you. Especially the results of the survey will be very helpful.
Okay, and AMGA, and we have great lobbyists here. I say, yeah, as my grandma would say, without fear of contradiction. But when we partner with the members, it makes us just all the more stronger. So, and that's our call to action. I believe we have almost running out of time, but this is a big issue for all the members. And we look forward to working with you as we work on these cuts. And that's it. Thank you for your time and have a good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.